Good morning. This is Dr. Elliott Sherr. I'm a professor of neurology and pediatrics at the University of California, San Francisco. I've been one of the principal investigators of the Simons VIP study that, as you know, has been primarily focused on trying to understand the clinical condition associated with 16p11.2, both deletions and reciprocal duplications. And today I'm going to talk about work done by a number of investigators on the neurologic findings associated with this condition. So you can see in this first slide here that what we've tried to do is schematize the different kinds of questions that have been asked in the study. And the two that have been circled in red, neurologic history and examination, and epilepsy history and records, are going to be the focus of my discussion today. However, we've also generated webinars for these other areas, including the imaging piece that's on the right, and I encourage you to pursue these if you're interested. So the first thing that we did was a detailed medical history. This was a history that was obtained from mom and dad, and then verified by a neurologist who is a member of the investigative team. And the neurologists also examined patients, and so this data together, both the history data and the exam data, went together to generate some of the data that I'll be talking about, including this table right here. And so what we've outlined are aspects of the neurologic exam and the history that pertains to neurologic findings that are elevated in deletion or duplication carriers compared to typically developing children, and also comparing them to each other. So the far right column that says Del versus Dupes are those where they're highlighted, where the p-value says, for instance, 0.01. That means that there's a statistically significant difference in the frequency in deletions versus duplications. But any of the ones that are highlighted in bold in the two middle columns suggest that those are features that are elevated in either deletion carriers on the left or duplication carriers on the right compared to the general population. So, for example, in the category under head, there's both macrocephaly and microcephaly, and you can see that the deletion carriers, that 17% of them, so 14 individuals out of a total of 83 individuals evaluated, had a head that was larger than normal. Conversely, microcephaly was present in 13 individuals who were duplication carriers, 13% of duplication carriers, meaning 10 out of the 76 total that were evaluated. And let me just add that these numbers, 83 and 76, are quite large for this kind of study, and that provides us a greater degree of certainty with regards to these findings. So other features that are elevated include hypotonia and weakness that you can see under the motor category, and duplication carriers have elevated tremor in comparison to controls, as well as in comparison to deletion carriers, and seizures in the form of epilepsy are present in 22% of deletion carriers and 26% of duplication carriers. So even though both of these are highly elevated relative to the general population, they are not different from each other, and that p-value of 0.7 reflects the similarity as opposed to the differences between those two. So you can refer back to this table later on as you're reviewing it, but I want to then now move forward and highlight some of the specific findings. So the first one that I'm going to talk about is macrocephaly, meaning an enlarged head. And you can see on this graph that's displayed in the middle of the slide, that there's a series of lines, and the top dark black line and the bottom black line represent the range of normal head circumferences, such that the bottom line is the 5th percentile, meaning that 5% or less of individuals in the general population will have a head size that small. Conversely, at the top, it's 95th percentile, meaning that 5% of individuals will have a head that's bigger than is represented by that line. And so the y-axis on this graph is head size, and the x-axis on this graph is time. And so the curve, as you can see, starts out with a higher degree of change. And so in the first year of life, there's an accelerated head growth, and that while the head continues to grow beyond 12 months, so 12 months is right here, it grows at a slightly slower rate. And what I've shown here in red is a possible line that somebody with macrocephaly would have. And you can see here that the size of the head is, throughout the time of development displayed, always larger than the general population. And that would come under the diagnosis of macrocephaly or enlarged head. And you can see here again that deletion carriers had it 17% of the time, but none of the children that were duplication carriers had macrocephaly. Now, by comparison, in microcephaly, as you can see here displayed in this child with a smaller head, in comparison to a more normal head, we're just looking at the opposite end of the spectrum. And so again, this red line is underneath the 5th percentile throughout its extent. And in reverse, we see that 17% of duplication carriers had microcephaly and none of the deletion carriers had microcephaly, suggesting that there is a reciprocal relationship between the two genetic conditions. In addition to head size, there was a report of both weakness and decreased tone in individuals with both deletion and duplication. And you can see two pictures here. The one on the right is a picture of a child with normal tone. And so when he's placed in this, what we call horizontal suspension, he's able to keep his head slightly elevated and his legs flexed and his back straight. Whereas in comparison here to a child who has truncal hypotonia, the child's not able to maintain the back in a straight position and the head is falling with gravity. And that was present in roughly half of deletion carriers and slightly less than half of duplication carriers. So quite a common but maybe non-specific feature of these conditions. In addition to hypotonia demonstrated by that horizontal suspension, you can also measure how well a child is able to support his head when pulled up by the arms. And again, on the right, I've demonstrated a example of a typically developing child with normal tone, and he's able to keep his head in line with the torso, whereas this child here, he's probably both weak and hypotonic. He's unable to keep his head suspended, and the head, which is quite heavy relative to the body early on, lags behind, and hence the term head lag. Okay, so in addition to those features that we see in individuals with 16p, seizures are often quite common, and as you recall from the earlier table, I noted that seizures were in greater than 20% of deletion and 20% of duplication carriers. So the data here is on the 18 deletion carriers and the 20 duplication carriers and what kinds of seizures they had. And so I've highlighted the 3 types of seizures that are the most commonly seen in these individuals. And so the most common one or the two most common ones are focal dyscognitive seizures, and I'm going to show an example of that on a video. And then the other one that's also quite common are called generalized tonic-clonic seizures. These are often referred to as grand mal seizures, whereas conversely, the one underneath it, what we call absence seizures, have sometimes been referred to as petit mal or small bad seizures. And those are more prevalent in deletion carriers and not so prevalent in duplication carriers. So in addition to observing individuals having seizures and making a diagnosis that way, we can also look at the electrical signature. And so what this shows you here in the graph paper on the bottom of the slide is the electrical activity in a normal individual who is not having a seizure. And what I've displayed here on the right top part of the slide is a schematic of how the electrodes are attached to the scalp, and what we're typically doing is measuring the electrical potential between two different regions. So for instance, between FP1, so in the front on the right, and F7 in the sort of more towards the frontal middle on that same side. And each one of these that are drawn next to each other generate a signal of electrical activity that's represented by these squiggly lines. And this amount here is actually normal. By comparison here, you can see in this slide that there is normal activity, a mixture of medium amplitude, so the height of the waveforms, and smaller amplitude, the smaller waveforms, and then suddenly, out of the blue, you see electrical activity that's very, very large in amplitude, and the frequency with which they occur actually slows down a little bit, and it's present throughout the brain. And this is what a generalized tonic-clonic seizure looks like. And you can see, if you look carefully back, that there's more increased activity just a moment or so before the seizure begins in certain areas. And that allows us to potentially determine where in the brain the seizures are coming from. Okay, so now I'm going to show you an example of what's called a focal dyscognitive seizure. It used to be called a complex partial seizure. And what this is a seizure that starts in a region of the brain and then spreads throughout the brain. And so what you'll see is somebody who looks agitated, and it's because he's actually having a seizure and it's bothering him. And then he'll go into physical movements of the seizure spreading, and at the end he'll have stiffening of his whole body, what we call the tonic phase, and then he'll have an additional piece that's called the clonic phase, where his arms are shaking. And let me play this for you now.
In that, although it begins with confusion and the other automatisms we've seen previously, this also, after a period of time, spreads into deep parts of the brain, and he goes on to have a frank tonic-clonic seizure that has secondarily generalized from the partial onset. And now we're into a typical tonic phase of the attack with his arms stiffly extended, and the same is commonly true of the legs at the same time. This lasts perhaps 10 to 15, 20 seconds, and then begins to slow progressively into the clonic phase of the seizure. Again, this gets slower and slower, and then after about another 15 to 30 seconds, we'll stop. During this part of the attack, the patient may bite his tongue, may have incontinence, and
Okay, in this next slide, I'm going to show an example of a absence or petit mal seizure. In this case, what happens is the individual is going about his normal activities, and there is a sudden what we call behavioral cessation. So he stops what he's doing and appears to stare off. And then just as abruptly as the seizure started, it'll stop, and he'll go back to his activities as if nothing else had happened. So that's the behavioral cessation. And then now he goes back to his activity, doing exactly what he was doing, opening up a package of what looks like crackers as part of his lunch. Okay. In addition to epilepsy, there are other features that we found on the neurologic exam, and these have been highlighted here. So unlike the ones above, which were history findings, these are findings that the neurologists themselves identified when they had an opportunity to examine the patient. And you'll see here, I'm going to point out a few of the features. We've talked about hypotonia, and you can see that hypotonia is present again globally in almost half of the deletion carriers and almost half of the duplication carriers. And the number of individuals, 136 and 110, are listed above. There's also hyporeflexia, meaning decreased reflexes, and a smaller number of individuals, including 30% of duplication carriers, have hyperreflexia. So let us go through some of these findings. So one of the findings that we observed were what are called café au lait spots, meaning literally like the French, coffee with milk, and so it has that kind of middle brown discoloration on the skin. It's more evident in individuals that are lighter skinned, but can also be seen in individuals such as the one on the left here who have darker skin by nature. These tend to be range from 1 to 5 or 6 centimeters in size at their longest extension. These are often seen in individuals that have disrupted development in what is referred to as the neural crest, which is a part of the nervous system that includes peripheral nerves, but also includes the cells that make pigmentation or melanin. And so these are abnormally active patches of cells that are making skin pigmentation. Another feature that we see in individuals is what's referred to as a sacral dimple. So the example that I'm showing you here is a child who has what's referred to as a myelomeningocele, and in that case you have both spinal compartment tissue, so in other words the spinal cord and the surrounding fluid actually sticking out in a sac at the bottom of the back, and that's something quite uncommon, and we didn't see that in any of the individuals with 16p, but we did see potentially evidence for spina bifida occulta. And so the concept behind this is that as the spine develops, it needs to zip up and create a fully closed tube that contains all of the spinal contents. But in some individuals, that does not happen either at the very bottom of the spine or at the very top of the spine. And we saw evidence of a sacral dimple, which may point to this as an example that needs to be investigated further. So this is just a schematic of how the neural tube closes. And so you can see here that it forms a pinched off area in the middle, and then this opening here at the bottom and this opening here at the top close up as if there's a zipper going both towards the head as well as towards the base of the spine. And this is a part of early development of the brain and the rest of the central nervous system. Now, how does this manifest? If there's an abnormality in the bottom of the spine. Oftentimes you'll see a dimple, and so this is a example of a dimple here, so an indentation. And the question is that indentation attached to, in the case demonstrated here, of a abscess or an infection of that area that's inside of the back that's connected by this little dimple, which actually ends up being an opening. And so again, if anyone has a dimple like that, you want to have the doctor take a look at it to make sure that it's just a cosmetic dimple and not a medically actionable one. Okay. Now again, I mentioned that we saw increased and decreased tone. Earlier on in the talk, I showed examples of children who had decreased tone, and now I'm going to show an example of an individual who has increased tone but also increased reflexes, so that when you tap on the knee, instead of having a single smooth and not very rapid movement of the lower leg, you have a rapid and stiffened movement of the leg, and it repeats itself from increased reflexes, hyperreflexia, and also hypertonia.
Well, we'll be careful on this side. Okay, so L4. Okay, and look, we have some clonus in the leg. We can stop it by pushing on the Golgi tendon organ just above.
That it takes quite some time for the leg to stop moving on its own, suggestive of increased reflexes and increased tone. And then I'm going to show an example of a tremor. And you can see here that his hand is twitching even though he's trying to hold still. And the same thing is happening with his leg. And we refer to that as this particular one as a resting tremor, and it's sometimes seen commonly in Parkinson's disease, and individuals with 16p appear to have both this resting tremor as well as an action tremor, meaning that as they try to move to grab something, their arm will shake and they'll have less control. Okay, so in this short talk today, I've focused on two aspects, one being neurologic history, and along with that, epilepsy history, and then I focused on the neurologic examination and the additional features that we could gain from looking at that. And then again, just to remind all of you who are listening to this webinar, even though I'm providing you this information, this was very much a team effort, and this is both the imaging scientists as well as the neurologists that make up the Simons VIP investigative team. And there are others as well from the Simons Foundation, as well as those who did the cognitive evaluations, for which there's additional webinars for you to peruse. Thanks very much for listening, and if you have any questions, please don't hesitate to reach out to me directly or to reach out to the